right, I'm just going to go through. Hello, everyone, and welcome to the PracticingDentist.com Liftoff Academy training event. This month, we are discussing oral surgery and endo. It's the Oral Surgery and Endo Bootcamp. So thanks to all of you who checked out the live training video this year. We've got some cool stuff to discuss today. So whoever joins, just pop in and we'll just continue to go through. And this event will be recorded and I'll probably post it for additional training for you guys. So I love oral surgery and endo. The reason why I thought it was a great topic to discuss in Liftoff Academy is this. New dentists graduating dental school, 1 year, 2 year, 3, 4 years out, find that oral surgery and endo are two of the hardest areas of dentistry to tackle. And I think that's because we get the least experience and least training in those specialties in dental school. So you get out, and what tends to happen, which I think can be avoided, is dentists graduate and they have a couple bad experiences in endo and oral surgery. And little by little, they start to defer more and more cases. And then when it's time to buy a practice, they start their practice and they don't do any of their own specialty work. And they start sending all these cases out. Well, what happens with those cases, those spots in your schedule that used to be for the molar endo or even the anterior endo or the upper edentulation for immediate denture delivery, you end up sending all those cases out. Well, to keep busy and to make profit or stay profitable at all, you have to fill those empty spots with less valuable procedures like single tooth operative. So the reason why I think it's important to discuss oral surgery and endo with new dentists and new dentist training is to give you guys the tools to make it simple, predictable, and to learn the mistakes that a lot of us have our first couple years out that end up causing us to give up and refer these cases out. So if you can slowly tackle them by kind of learning the basic principles that I teach, what to avoid, what to look for, step by step, what cases to tackle, where to start, what to do when you get into trouble, slowly you get more and more experience, and those endo and surgery cases will, after a couple years, become a norm, and they'll add a lot of profit. You'll fill up your schedule with bigger cases that you can keep in-house, an income that goes in your pocket, not somebody else's. So that's why I think it's so important. I think too often, especially nowadays, we get sent out into the real world and we have a couple bad experiences and we end up giving up. So look at the oral surgery and endo boot camp and learn the mistakes that I've found a lot of dentists make and how to avoid them. And if you do this, and a lot of them are really basic step-by-step principles, you'll be able to tackle and get more experience on difficult cases. So again, I found a really interesting oral surgery partner for PracticingDentist.com, somebody in our network who is a great resource and is a periodontist in Beverly Hills, California, who is a great online site complimentary to PracticingDentist.com that teaches complex, simple, basic, intermediate oral surgery skills. And it's mostly online, a lot of it YouTube and a lot of it's webinar based. So his name is Ziv Simon, and he has a great book, which is just a simple guide called Money Tooth, talking about the first molar, which is a great starting point to discuss how to tackle difficult oral surgery, because often that money tooth, the mandibular first molar, is the first one to go or the first one to have issues and the most frequently removed tooth. So I'm going to pull it up. I'm going to share that screen with you, and we're going to go through just some basic points to highlight and supplement what we already learned in the oral surgery, endo, and boot camp video. So I'm going to share my screen here in a sec. All right, guys, I'm going to pull that up. There we go. So I'd like to walk through this with you guys. This is the money tooth packet, and I sent a link out. I posted it on our Facebook Liftoff Academy mastermind group, which if you haven't joined, you should. It is a great group for practicing dentists, new dental graduates, kind of a club where people can post. I can teach kind of special content. things apart from the practicingdentist.com site. You can ask questions, and I'll post additional resources. So I posted the link on that site to download this book. And I talked to Zevin. He's a great guy. He said, go for it. Sign up for his course. Surgical Master is the name. Check it out. And there's a lot of great things for new dentists. You guys have heard a lot of this in oral surgery, or for those of us who didn't get a ton of oral surgery in dental school, maybe not. So this simplifies, step-by-step, breaks down what to avoid, what's difficult, when the red flag should go up. We've been taught about what we should be doing, how to take a tooth out, but you should also be taught when not to, or when it's going to be difficult, because you need to identify the difficult factors, or like Ziv talks about here, the enemies, the extraction enemies, and be able to slowly walk through step by step how to remove difficult teeth. So let's start here. We'll go down to, there's a lot of stuff, read through each step, but talking about here, like we talked about in the other Liftoff Academy training video, 95% of your prep comes from evaluating the radiograph. So after you get your patient in, you manage your patient, see if they're ready to go through with it. You look at your x-ray and you decide, what are my difficult factors here? What are the things that are going to make this extraction a time killer? And I'm a big advocate for putting, especially in the beginning while you're really getting comfortable with oral surgery, putting oral surgery in endo, maybe at the end of your day, or in time blocks, maybe before lunch, where if you go over, it's not going to kill the rest of your schedule, because these extraction enemies are the things that cause a 20-minute extraction removal into a 2-hour, and then a referral to the specialist, and a lot of embarrassment and stress on your part. So start with a radiograph. So we're looking at a couple different things, and as it goes down here, extraction enemies. So endo-treated teeth, restorations, heavily restored teeth are going to fracture apart. And what happens then is you have no purchase point, you have nothing to grab onto. It makes it pretty difficult. Periapical pathology, the reason that's an extraction enemy is your anesthetic. It's pretty difficult to anesthetize a tooth that's really inflamed. If you have a ton of infection down there, a lot of purulence and inflammation is going to cause a pH problem with your anesthetic, and it's be really difficult to get numb. Poor tissue, so really edematous or unhealthy tissue has a possibility of tearing. Shape of adjacent roots, you have to watch that. If they're flared, if they're bulbous at the end, going to cause a lot of difficulty removing those root tips if they fracture. Adjacent restoration is important. Can you lever on the adjacent teeth? Is it an implant? Is it a crown? We're all going to get in that point. We start removing a tooth, and all of a sudden, boom, the crown pops off of the adjacent tooth. Hopefully it didn't fracture, cause irreversible damage, but you're going to hopefully be able to bond that back on the fly. But just be aware, those are the things you're looking for. You fracture a patient's adjacent amalgam or composite, you're going to end up redoing that for them. They're going to ask you why you broke their tooth. Nerve space proximity, again, beware of vital structures like we talked about in the boot camp lecture. Root proximity, adjacent roots can cause a difficulty just because you don't have a lot of room to get fractured root tips out. It's hard to lever, it's hard to get expansion of any of the surrounding bone around your tooth, which that expansion allows you to remove those root tips if there's a root next door or right up next to your molar root. Caries and resorption, again, you're going to have fracture of that crown. It's going to be difficult to remove. Any fractures to your molar, if you're not used to sectioning or removing root tips, any fractures are going to cause major complications. And dense bone. So dense bone is hard to evaluate at first, but you should be able to see it on your radiograph. And a lot of the times you can look at the PDL space too to see how big that is. In an endo-treated tooth or a tooth with really dense bone, you're going to get really thin PDL space around those roots. So watch that. So extraction enemies, and he goes through one by one. It's pretty neat talking about each one to show you pictures. Endo-treated, again, the reason endo-treated is difficult is usually you have possibly a little ankylosis of the root, and then you get fracture of the crown. Existing restoration, same thing. You have fracture of that crown, which then causes difficulty if there's really dense bone to remove those root tips. Periapical pathology having to do with the blocks. So a little tip here on blocks or anesthetic at all is I would do what I typically do is give them 2 carpioles, usually use lidocaine, in an IN. This is for a lower anesthesia. And then I'll do a buccal and lingual infiltration with septicane. I'll usually do a carpule, and I'll probably put it half on the lingual, half on the buccal. And then I'll often take another carpule of carbocaine or lidocaine and do a PDL injection. So I'll try to get it right up next to that PDL space. If I have a Ligajet, that's great. That's a little easier to use. That pushes anesthetic right into that PDL space, and that infiltrates down to help anesthetize. But I often use a 30 gauge also instead if I'm lazy and don't want to get my Ligajet out. If I do those three things, if I'm taking out a tooth, honestly, I would go right to at least 3 carpules right away. Don't mess around. Don't do it little by little. You need to get them numb as fast as you can. So 2 carpules, and then 1 carpule septicane, buccal lingual with an additional maybe 4th carpule in a PDL. You're not going to get a whole carpule in a PDL injection, but get one out, give them a little bit right down the PDL. You have to push pretty hard. That's when you know it's working. Poor tissue, again, thin. If you have thin tissue, you're going to get tears, so be careful. You might need to release this, and that's where flapping and learning and getting comfortable with that is really important. Because if you learn all of these things piece by piece, they all work together to make cases easier for you. Flapping, reflecting, suturing, sectioning, things like that. So if you're going to jump into oral surgery, get ready to learn all of those things and be good at all of those things. Shape of the roots, again, bulbous root at the end, endo-treated tooth, fractured crown. You're almost certain to have to section this tooth right down the middle and then rotate out and look at the direction. That's what I talked about in our Liftoff Academy. Look at the direction of this canal. That's the direction that root's going to want to come out. So where do you start? If you start levering back this way, you're going to fracture that root. It's not going to work. So you need to come out towards the distal and then remove this distal root. Adjacent teeth, adjacent restorations, be careful. You have to be careful not to put your elevator into this space and really start wrenching left and right. It's really delicate. This is a difficult tooth. Look at the bone, look at the root curvatures. And the nerve space proximity, kind of always get an idea where the IN is, usually on a molar. It's way down below the root tips, but just be careful, especially at the end if you're going to start curetting. Be gentle. Root proximity, and this is where I was saying the root proximity comes into play. You are not able to expand the cortical plate, expand the bone, and that expansion allows for space to remove your root or remove the tooth. So if you're up against an adjacent root, you're not going to expand anything. You're going to be hammered against that stone wall, and it makes it difficult. So these are all pictures to look at. To get in mind. So when you jump out and you're in private practice, some of you guys that have been out 1, 2, 3, 4 years, you can begin to identify, like Ziv says, these extraction enemies. Dense bone, again, dense bone. Look at these really long roots, thin PDL space, endo-treated, there's posts. Dense bone, a lot of striation. And it's kind of a trick too to start to identify, but you can see where's the bone level on the crown. Is there bone loss? Not really. That's going to be pretty dense bones, pretty difficult to get out, and it's going to be a bear if you break a root tip. So going down, he talks about surgical kit, which we talked about too in our lecture. I talked about anesthesia. So again, brush up on that. This is all worth looking at. So here's 9 guidelines. This is great. So this is kind of step by step what I do similar as well. First step is to luxate the tooth around its axis. So get a forceps on there. If it's a lower molar, I'll get my cow horn and 23. See if I can seat it down into that furcation. And I'll give it a little rotation, little left, right, little up and down, kind of pumping action on that 23 to get some mobility. If I can get my 301 elevator in first, that's the first thing I start out with. And I kind of do a rotation up and down to see if I can get some mobility in that tooth. If not, then you're going to probably surgical. So if there's no mobility after a minute of trying to use your forceps and that 301, then you're going to jump right into section that tooth. If it has a crown, I'd first try to remove that crown. If you get a 23 on there, I'd squeeze and pop that crown off. A lot of times that makes it easier. Then you don't have to section through the crown. It's probably going to come off anyways later, so try to get it off right away if you can. Remove the roots separately, with or without coronal part. I like to keep a little bit of the coronal part, because if you have a purchase, maybe you can get an ash or a lower forceps on there, to remove a root where it has coronal structure. If you start to fracture down to the level of the bone, it makes it more difficult. You have to usually get your handpiece down and trough a little bit to be able to get a purchase on that root tip. So flap reflection is common. Be able to reflect a flap. If you're going to start to get into surgical procedures, don't be afraid to flap. Just do it well. If you're going to go in, go all in, and learn to reflect far enough. Be aware where your vital structures are, because that's kind of your limiting factor. But that's going to help you see, and that's really important when you start jumping into surgery. Don't lean against adjacent teeth. You can cause damage, especially when you look back and you see that, yeah, we have an old crown or an old amalgam. Then you have to be really gentle with your elevators. Thin curved roots. Create a space between the roots. That always really helps in the furcation. And if you trough, it will allow you to place your instruments. Your elevators are going to be able to get into certain spots. So like I talked about in our training video, remember to make room. That's what's going to go off in your head when you start to have issues. I need to make room somewhere. Where is there a spot where, A, I don't need the bone? And again, assuming you aren't placing or planning to place an implant in this site, because if you are, removing bone is not going to be ideal. And those cases are definitely bumped up to the really expert level. So if it's an implant site, be really careful, because you're liable for what happens during the removal of that tooth. But if it's an area where you can easily trough and you're not planning an implant, then great, make some space. Take out some bone automatic in between the roots. That's if you're going to lose bone somewhere, that's probably the number one place, or least damaging place to do the socket healing, and bone loss through healing is if you remove furcal bone. So go into the furcation, remove some bone, trough if you need to on the buccal, and that helps. Socket grafting is great. If you guys are going to get into surgery, socket grafting is easy. If you want to know how to do that simply and easily, it adds $200 to $300 extra onto the end of your extraction. Very profitable. And also it's great because if you're going to plan to do an implant here, even down the road, I give the patient an option and just say, hey, Mr. Smith, if we remove this tooth and we don't protect the bone, you're gonna lose 20 to 30% of bone within this first year, and we want to preserve that site. So later on, you could have the possibility to get an implant in there. And if you present it that way, a lot of times people will like to preserve bone and give themselves at least the option to do an implant later on down the road. Resorbable sutures, membranes. In terms of socket grafting, I would use just a collar plug. I just cut a collar plug in half. Those are easy. You guys should have those around the office if you're going to do surgery. And resorbable gut sutures. I use usually plain gut or chromic, but that's a great option to have those on hand because that's what you're probably going to use. And he goes through to talk about some other good little techniques on how to section and remove those root tips. What if they break? And then have a plan. And so he's got some great info here. Anyways, go through that. I think you guys will love it. I'm going to be posting some more of his stuff down the road as well. It's a great option. So anyways, guys, let's do a little Q&A here. And if you're not a practicingdentist.com subscriber, please subscribe because we've got great training info. It allows me to communicate better with you guys. And it's awesome to continue to learn stuff like this that you're going to see in private practice or you are seeing if you're a couple years out. And also join these coaching calls because you can always ask questions and have a resource at least to bounce ideas off of. And I've got a great, awesome new resource coming out. It's called the Dental Associate Network. And the website is www.dentalassociatematch.com. And check it out. For all of you guys who are not practice owners yet, there's now a resource to subscribe to. It's free, and basically just put in your info like a resume, and then they have a network of dental owners that are looking for associates that they want to match to. And the cool thing is that we partnered with Dental Associate Network to be able to offer our practicing dentist training content for dental associates. So it looks good for you guys too to say, hey, I've been getting some training about how to succeed in private practice, some training on dental business and advanced procedures. So it's kind of neat. It's an endorsement that you get through practicingdentist.com for Dental Associate Network. And then what you do is you sign up in your area, and if a job pops up and you qualify or there's interest from the owners, they'll contact you and set up a meeting. And basically it's a place that finds associate jobs for prospective associates. So it's great. Check that out, and they can match you guys up. Other than that, thanks a lot. Keep an eye out on our Facebook posts and join our mastermind group, and check out Ziv's content. It's pretty interesting, and we'll keep rolling out every month with more training videos. Awesome. Thanks, guys.